Hello everyone, welcome back to my channel. Did you know invisible microorganisms can bring about inflammatory changes in your brain? To an extent that may make you insane or worse, dead. Yes, you are quite right, it is meningitis. Meningitis poses a significant public health threat, despite successful efforts to control the disease globally. The burden of morbidity and mortality from meningitis remains high, particularly in low and middle-income countries and in settings experiencing large-scale, disruptive epidemics. Approximately 1 in 5 individuals affected by bacterial meningitis incurs long-term complications, which may result in disability and have a profound impact on quality of life. The World Health Organization has published its first-ever global guidelines for meningitis diagnosis, treatment and care, aiming to speed up detection, ensure timely treatment, and improve long-term care for those affected. By bringing together the latest evidence-based recommendations, the guidelines provide a critical tool for reducing deaths and disability caused by the disease. Dr. Tedros Adhanom Ghebreyesus, WHO Director General said, "Bacterial meningitis kills 1 in 6 of the people it strikes, and leaves many others with lasting health challenges. Implementing these new guidelines will help save lives, improve long-term care for those affected by meningitis, and strengthen health systems." The guidelines contribute to the broader Defeating Meningitis by 2030 global roadmap, adopted by WHO member states in 2020, which aims to eliminate bacterial meningitis epidemics, reduce cases of vaccine-preventable bacterial meningitis by 50% and deaths by 70%, and reduce disability and improve quality of life after meningitis. The WHO guidelines on meningitis diagnosis, treatment and care provide evidence-based, quality-assured recommendations for the clinical management of children over 1 month of age, adolescents and adults with acute, community-acquired meningitis. The guidelines provide recommendations applicable worldwide and are primarily intended for healthcare professionals working in first or second-level healthcare facilities, including emergency, inpatient and outpatient services. Additionally, the guidelines are directed at policymakers, healthcare planners and program managers operating at national and international levels, e.g. ministries of health, national public health bodies, non-governmental organizations. The recommendations are organized into 3 sections: diagnosis, treatment and management of sequelae. A combined, integrated approach to the interpretation of CSF findings is required to mitigate and minimize the risks associated with the diagnostic performance of individual tests, i.e. risk of false negatives and/or false positives. In individuals with suspected acute meningitis, cerebrospinal fluid investigations should be performed to determine white blood cell count, total and differential, protein concentration, glucose concentration and the cerebrospinal fluid to blood glucose ratio. The diagnostic yield of these CSF laboratory investigations may decrease when antimicrobial treatment is initiated prior to lumbar puncture. Cerebrospinal fluid culture and antimicrobial susceptibility testing remain the gold standard for bacterial pathogen identification. PCR-based molecular tests for relevant pathogens should be performed on cerebrospinal fluid samples. Cranial imaging should be performed prior to lumbar puncture to rule out cerebral space-occupying lesions with midline shift, if any of the following features are identified at time of presentation: Glasgow Coma score below 10, focal neurological signs, cranial nerve deficits, papilledema, new-onset seizures, in adults, severe immunocompromised state. New-onset isolated seizures in children do not require cranial imaging prior to lumbar puncture when they occur in the absence of any other at-risk features. When lumbar puncture is deferred, blood samples, including blood cultures, should be collected, and antimicrobial treatment started as soon as possible, prior to cranial imaging. For people living with HIV suspected of having a first episode of cryptococcal meningitis, prompt lumbar puncture with measurement of opening pressure and rapid cryptococcal antigen assay is recommended as the preferred diagnostic approach. In children and adults with suspected or probable acute bacterial meningitis, intravenous ceftriaxone or cefotaxime should be administered as empiric treatment. In the presence of one or more risk factors for Listeria monocytogenes infection, i.e. age over 60 years, pregnancy, immunocompromised state, intravenous ampicillin or amoxicillin should be administered in addition to the initial antimicrobial regimen. Antimicrobial treatment should be administered intravenously. If intravenous administration is not possible and/or an intravenous line is not secured, intramuscular administration should be pursued. After admission or transfer to an appropriate healthcare facility, intravenous antimicrobial treatment should be given as soon as acute bacterial meningitis is suspected. The 1-hour window is generally regarded as the golden time period to initiate empiric antibiotic therapy. Lumbar puncture, in the absence of contraindications or reasons for deferral, and blood tests should be performed prior to initiating empiric antimicrobial treatment. However, any delay in diagnostic investigations should not delay therapy administration. In the absence of contraindications or reasons for deferral, individuals who have received antimicrobial treatment before admission should undergo lumbar puncture as soon as possible once they are admitted in an appropriate healthcare facility. When the pathogen remains unknown, empiric antibiotic therapy can be discontinued after 7 days, provided that the person has clinically recovered. Clinical recovery may be indicated by the presence of all of the following for at least 48 hours. Resolution of fever, resolution of vital sign abnormalities, blood pressure, heart rate, respiratory rate, oxygen saturation, resolution of altered consciousness, normal mental status. In the absence of clinical recovery within 1 week of empiric treatment, antibiotic therapy should be extended and accompanied by an appropriate diagnostic workup, including a repeat lumbar puncture provided there are no contraindications. During meningococcal disease epidemics, empiric treatment with parenteral ceftriaxone should be administered for 5 days to children and adults with suspected or probable meningococcal meningitis. In non-epidemic settings where lumbar puncture can be performed, intravenous corticosteroids, dexamethasone, hydrocortisone or methylprednisolone, should be initiated with the first dose of antibiotics in children and adults with suspected acute bacterial meningitis. If cerebrospinal fluid characteristics are not consistent with bacterial meningitis, intravenous corticosteroids should be discontinued. During meningococcal disease epidemics, intravenous corticosteroids, dexamethasone, hydrocortisone or methylprednisolone, should not be routinely used in children and adults with suspected or probable meningococcal meningitis. During pneumococcal disease epidemics, intravenous corticosteroids, dexamethasone, hydrocortisone or methylprednisolone, should be initiated with the first dose of antibiotics in children and adults with suspected or probable pneumococcal meningitis. Other adjunctives are osmotic agents, fluid management and anti-seizure drugs. When hearing loss is detected, urgent referral for hearing rehabilitation or evaluation for cochlear implantation should be arranged. This is crucial to prevent the rapid impairment of speech due to the loss of auditory feedback and to avoid cochlear ossification in individuals eligible for cochlear implantation. In children and adults with acute meningitis from any cause, formal audiological screening should be conducted before discharge. If audiological screening is not possible before discharge, it should be conducted within 4 weeks of discharge. Individuals screened before discharge and found to have no hearing loss should undergo a second formal audiological screening test, as a small number may still develop hearing loss at a later stage. Children and adults with acute meningitis from any cause should be reviewed for sequelae by a healthcare provider prior to discharge and at follow-up. A clinical assessment at follow-up should be performed at least once within 4 weeks of discharge. When sequelae are detected, referral to the appropriate services should be arranged. When available, psychological support should be offered to both the person with meningitis and their caregivers. In children and adults with sequelae due to acute meningitis from any cause, Rehabilitation should be provided as soon as possible. That's for today. You can find the detailed guidelines shared on my WhatsApp channel. Link is in the description. Do subscribe and press the bell icon to never miss an update on further new informative videos on MedLoom. Also like, comment and share with your friends. Stay healthy. Bye.